Good afternoon. I'm Palma Shah. This is Dr. Prem Gupta. We're here to moderate the challenging cases session. We appreciate your time and coming here today. We have a great lineup of people presenting from all over the world. This is really derived under the auspices of the World Federation of Vascular Societies, and within that umbrella organization that sits over multiple national and international societies. There's the Global Training Initiative, which we've put together with young trainees or young recent graduates. And in those interactions that I've had with them, and in one call with Professor Greenhall, we decided to do a challenging case session. And this is really also in honor of his wishes that we conduct this. Subsequent to this, then we'll have a short leadership challenge session, which will introduce different speakers for that. And Prem will introduce.
Good afternoon, and without wasting time, we'll start with the first case by Palma on peripheral arterial disease, a challenging case.
I have no pertinent disclosures for this discussion. So this is a peripheral arterial disease challenging case that one of my patients, and this is sort of a cases I wish I hadn't done type of thing, so bear with me. It's a 64-year-old male with typical problems that we deal with: COPD, coronary artery disease, hypertension. He also had bipolar disorder and was referred for evaluation of peripheral arterial disease. His complaints were a little bit variable. He did complain of some spasms and from his feet to hips, worse at night, but he also did elicit a history of typical claudication in his calves, particularly worse on the right side. In fact, he said he couldn't even really do his grocery shopping because of the limitations of the right leg claudication. He was an ongoing smoker, and in part related to his psychiatric disorder, he was really unable to actually quit smoking due to underlying anxiety. And he was on an aspirin and Lipitor and medically optimized. On examination, he had a decreased right femoral pulse and a normal 2+ common femoral pulse on palpation. Bilaterally, on the right, he had a monophasic dorsal pedis and posterior tibial signal, and on the left, these signals were biphasic. I ordered ankle brachial indices to further assess this, and his ABI on the right was 0.67, and his toe index was 0.35, but on the left, it was much better at 0.86, although the toe brachial index was similar to the right side. So in reviewing this patient, he actually had already had 3 separate CAT scans done for different reasons before I ever met this patient. So this is the first one, and here as you watch this, I don't know if you caught that. Let me just see if I can go back one. Particularly here, you can see a lack of opacification of the right common femoral artery. This is a subsequent study that was done about a month later, ordered because he had acute abdominal pain that was not a true CTA, but again, you see a paucity of flow in the right common femoral artery, and this was read as common femoral artery occlusive disease, and some disease in the distal right external iliac artery. And then yet, he had microscopic hematuria, and somebody else got another study. So by the time I saw this patient, it was about a month after that, and I didn't feel that with all the radiation that he's had, I felt that we would just plan to do a common femoral endarterectomy and bovine patch. And in my notes, I said, well, he's very thin. If I need to extend up onto the external iliac artery, that should be sufficient, and I can address this with one incision. When I exposed the right common femoral artery, I went up just above the inguinal ligament. There was some calcification, so I extended higher to where it was soft. I got control, I made my arteriotomy, and there was no antegrade flow. I tried to put a Fogarty thrombectomy catheter up, and I got some thrombus back. There was still no flow, so I knew there was a higher occlusion at that point. So at this point, I was rethinking what's really going on here. So fortunately, I did prep both groins, so I was able to actually access the left common femoral artery, brought the C-arm in. I hadn't planned to do this as a hybrid case. As you can see here, there was a very narrow, tight aortic bifurcation, and so it really affected the pushability. So even though I could get the wire over, I couldn't get much purchase to do that. And you see in the lower image, there's a retrograde sheath injection here, and so I had a problem. So again, I actually called a colleague, talked about this, and then decided to go via left brachial artery. So re-prep drape the left brachial artery, and I was able to actually get down, get an oblique, and then cross body floss. And then I ended up putting in a covered stent graft in to reopen that. And the conclusion of the case, we had inline flow. I put a long patch above the inguinal ligament, and the VBX was somewhat higher, and he had a normal ankle brachial index at the end of the case. So I guess we will open this up to questions or how other people might have done this differently.
Thank you, Palma. Any questions, comments from the audience? While somebody comes up, what really went wrong?
I didn't do a repeat CTA, but he had 3 CAT scans, so, for cost containment and all these other things, and I think it was a miss, I missed it.
Hi there, Matthew from Norway. Not every operating room has like a C-arm you can bring in. Did you consider doing a pelvic incision here and going retroperitoneal and opening up and doing a direct thrombectomy?
That's what I would have had to do if I couldn't have converted to a hybrid approach. Yeah. It was a little bit sticky more proximally. There was a lot of veins and things, so it would have been doable but tedious. So, and luckily I was able to cross. If I weren't able to cross, then I would have had to do a second counter incision and make a higher incision.
Yeah. Dr. Faris, I think you are right that we are not wishing to expose the patient to more radiation, but another option is to do MRA, and if his renal function is bad, we can do the time of flight MRA to have an idea about what's going on in his arteries in the lower limbs. So before we open the artery, we can plan for probably endovascular procedure.
That's a great idea, and I think that at least in the US, some people do use MR, but a lot of us actually use it less because the CTA is, in some institutions, is just a better quality software imaging package. And so in our institution, we don't use a lot of the MR, but that's a great idea. Thank you.
I would actually agree with him on that because we tend to perform non-contrast MRAs in most of our patients. And since many of them are diabetics and have borderline kidney dysfunction, we do a non-contrast MRA, and if we really want to look for calcification, we depend on either an X-ray or we do a plain CT and then sort of combine the images to see how to intervene.
Has anybody in the audience ever had to do that, to come brachial to try to cross a lesion you didn't anticipate was occluded? Would anybody have done anything differently from what I did? To bail yourself out, would anybody have done anything differently? No? Okay, thank you.
Thank you, Palma.
Our next presenter is Professor Philippe Cole, who will discuss a complex case in peripheral arterial disease representing the European Society of Vascular Surgery.
Thank you very much, Palma. Usually when I've taken the floor over the last year was to talk about guidelines or about the society, but it's nice to present just a easy or actually not very complicated case, but should trigger a few questions thought by one of my colleagues, Arno Kersman, and myself. So this, I have no disclosure. This is a female, 77 years old. It's actually the mother of one of our colleagues from the faculty. That's usually with this type of patient that you may run into problems. She was a heavy smoker, still smoking, despite several interventional procedures. She is hypertensive with hypercholesterolemia and got a few years ago cardiac pacemaker implantation for an AV block. She has recurrent intermittent claudication of the left leg. In this same leg, she had a superficial femoral artery dilatation 7 years ago. Or 6 years ago. This case was done at the end of last year, and the following year left external iliac artery stenting with a venous femoral popliteal bypass. The femoral popliteal bypass, as you will see, was rather proximal, meaning the distal anastomosis was just above the knee. She had a CT angio because of recurrence of symptom, with an ankle brachial index of 0.95 on the right side and 0.70 on the left side. This CT angio was performed in another hospital and showed an occlusion of the left SFA as well as an occlusion of the venous femoropopliteal bypass. So the strategy was to perform a contralateral femoral punction, attempt to recanalize the native left SFA using rotational atherectomy, and as needed dilatation with one or several coated balloons. As you can imagine, things didn't go that way. We had difficulties or impossibilities to perform the recanalization through an antegrade approach, and found out also on table that the left profundus femoral artery, so the deep femoral artery, was rather stenotic. So we performed a balloon dilatation of this artery. You can see the balloon here, and here the stenosis. So the strategy changed, and what we did, instead of passing the guide into the native artery, the guide actually entered quite easily into the bypass. So here you can see the distal part, the guide on the distal part. And so the procedure that we did was a rotational atherectomy of the bypass, of the venous bypass, which is quite unusual. You know, these procedures, usually you perform atherectomy on the native arteries or on a prostatic bypass, here on the left part. And you can see here at the end of the procedure with the proximal and the distal anastomosis. Now, the little complication was the development of a small or moderate-sized pseudoaneurysm on the proximal anastomosis that was not present before the atherectomy, so therefore is a complication of the atherectomy. 10 months later, the patient actually was seen at the clinic last week. She is asymptomatic. The bypass is patent by echo. The ankle brachial index is 0.9. It's about the same on both sides. The echo Doppler showed the stability of the pseudoaneurysm measured at 9 millimeters of diameter in its highest diameter. And at CT angio, the bypass is patent, and the pseudoaneurysm appears to be non-threatening. And we plan to see the patient again in 6 months. She is still smoking. Thank you very much.
So while people are coming up from the audience, so Philippe, that looked like it was a flush occlusion on that SFA, on the angio. Was it a flush occlusion?
Probably not. Probably not. It appears like that, but probably not from what we saw.
And the bypass graft had been taken off of the distal common femoral artery, or more proximal?
The more proximal, before the bifurcation. And the bypass had been occluded for probably several months. It was not acute occlusion of the bypass. It was an old occlusion. And strangely, it was quite easy to reopen it.
And what were you able to extract? Was it old thrombus? Or?
Yes. Mostly old thrombus and fibromuscular dysplasia, this type of thing that you usually see on bypass.
Hi, it's Hazem Hussain. I'm a vascular surgeon from Dubai. Just two questions. The first, she's a patient who's a claudicant smoker with an occluded bypass. So if I may challenge the indication for the procedure. Second question, she continues to smoke. We know, I'm a bypass surgeon, so we know that people who continue to smoke with a previously occluded bypass are likely to occlude again. If she does, what are you going to do?
Well, if I look at what we say also in the guidelines, I of course agree with you. I think that this is the type of patient who definitely should stop smoking and maybe should not have had the initial procedure, which we did not do. I mean, the surgeon showing this case, but it was done. And she was actually having increasingly shortened walking distance and probably was going to go into rest ischemia. We counsel her quite heavily to stop smoking, but you know that sometimes it's difficult. But I agree that there is a balance, and most of the case for the primary procedure, I personally think that when we have patients that only have claudication, so no rest pain and no threatening ischemia, we should send them to smoking cessation counseling and not do the initial procedure. But here the situation was a little bit different. Now, if she occlude again, I guess we may have to think about using another conduit for bypass, such as arm vein or vein from the other leg. But that's of course a little bit the danger also. So I agree. That's also why we decided to bring this case here, because I suspected that this type of question would come. So thank you.
But Felipe, you also treated it was a high-grade profunda stenosis.
Yes.
So even if this bypass were to go down, if that profunda remains open, it may provide better collaterals than she started with.
It's definitely, well, I suspect this was the most important part of the procedure, was to reopen the profunda. I agree, Palma, definitely, yes. Yes.
Question?
I have a question. I'm Rebecca Riachi from Mexico. Do you have in your country, by the government, a special treatment for patients to quit smoking?
What is you ask me whether the government give incentives to quit smoking?
Yes.
Well, yes. I mean, it will be reimbursed to some extent, of course. I think that we can do more and more about that. We actually, your question is interesting because I participated last week in a session with the European Parliament in Brussels to see how we could advise the Commission, the next Commission, and we advised quite strongly about patient counseling for various things, not only smoking cessation, but also screening for colorectal cancer and these type of things. So yes, partly, but I think that's insufficient.
Okay, thank you.
So Philip, there's one more question for you. What is your plan with the pseudoaneurysm? Do you plan to follow it up, or?
The plan to follow up the patient?
No, the pseudoaneurysm.
Oh, okay. Yes. I think if she remains asymptomatic, usually this type of patient, we see them in the clinics every 6 months.
And when you were doing the atherectomy, and before you actually saw the pseudoaneurysm, since you were dealing with a chronic thrombus, did you think of using thrombolysis?
There was no acute thrombus. This is why we didn't use thrombolysis. We went into immediately to rotational atherectomy because there was no acute thrombus. As I said, the occlusion and the pain at walking was there for, I think, remember correctly, 3 months.
We can have one quick question.
Yeah, I think this point is important. If you are planning to reopen the occluded venous graft, so probably you will do a pharmacomechanical first, and that will lead to less complications, because I'm not sure whether atherectomy in this case is against IFU.
I agree. As I said, that was not the original plan. The original plan was to reopen the SFA, but we couldn't enter it. And for some reason, unexpectedly, the catheter went to the bypass quite a way, and we were able to reopen it quite easily. Yeah, thank you.
Thank you, Philip.
Thank you very much.
So now we call on Dr. Pranati Swain from the Vascular Society of India. She will talk to us about the reverse slider technique for an angulated aortic neck.
Good afternoon, everyone, and my greetings from India. I would be talking about, I have no disclosures, and I'll be talking about sliding through a curved aneurysm via reverse slider technique. Okay, so first to go on about my case, it was a 67-year-old male who actually came to a neurosurgery OPD for which one MRI was done, I believe at a center not ours, and someone discovered a incidental finding of a large intrarenal abdominal aortic aneurysm, and then was referred to our center. So the CT angiogram showed an infrarenal autoiliac aneurysm at the size of 6.4 into 6.7 into 12 centimeters in the length. I think that was the best news we received that day. And the next news was the short neck from the lower renal artery that is on the left, and it has got an angulation of almost more than 90 degrees. And not only that, my previous slide, if you concentrate on this part, I should be able to draw here. Okay, if you look at the right iliac, it was tortuous with a single S curve, and the other side, the left iliac, again, had a double S curve in it. So, this guy had severe back pain by then, and we had a neck length. Not only the angulation was a challenge, not the tortuous iliacs, and the neck length was exactly 9 mm from the lower renal artery. So when we considered technique, when decided to change the technique to reverse slider, we could get from the right renal artery, lower renal artery, the length increased to 12 mm. So we did keep an option of doing a chimney through right renal artery and left renal artery if required, but we wanted to try out the reverse slider technique first. The device that we used was an Endurant graft, which is 36 into 16 and 145 mm. Since we had to extend more on the right iliac, so we decided to take the main body through the more tortuous left iliac artery. Please pardon me for the fluoroscopic images. I do not have much of how we crossed, but I have drawn a few pictures so that I could be able to tell you. So as you can see on the planning, the tortuosity of the both sides of the left and the right iliacs, and this was the CT image. And if I go on to how we cannulated the right iliac first through a stiff wire that straightened out the angle a bit on the right side. And the left side, we started with a Terumo, first with 014, and then we changed over to 035. We could take a catheter across it through the double curve. It continued to have a 360-degree rotation during the entire iliacs, and then we carried it up. Next was we put in a large sheath through it to straighten it out a bit, and with a Lundquist wire. This was the final first check angiogram that we took. And during the deployment, you can see the device is at the right renal artery, just ahead of right renal artery. And with the reverse slider technique, we have approximated the right renal artery. The left renal artery approximation is complete in the proximal, and we achieved a proximal C-link. We extended through the iliacs. There was mild endolic type 1B, no type 1B endolic. At the end of 15 minutes, we took another check angiogram, and this was our final angiogram. Coming on to the on follow-up, this is after 2 months. There has been no endolic in the sac, and the graft had approximated nicely into the aneurysm. There was no remaining, the sac had thrombosed completely. Thank you very much. I would like to take any questions if you have.
Hi, Hazem Hassano again.
Yeah, go ahead, please.
Why not consider open aneurysm repair? 67, angulated neck.
Yes, the amount of calcification around the A and in the outer, yes, open could have been we could have converted into it. But EVAR was also a possibility, and he also had other comorbidities, like he was hypertensive, diabetic, plus ejection fraction was somewhere around 50%, so we didn't want to take that risk. He had no kidney disease as such, but we didn't want to take the risk with the cardiac issues.
Pranati, I think some people have doubts about what is the reverse slider technique. Could you briefly describe that?
Yes. Basically, whenever it is to simplify it a little more, what happens is whenever we take a device, aneurysms are not straightforward straight tubes in which you put in another tube and it is approximated. So when you get a curved one, you want that fabric to be apposed correctly into that tube, right? For that, what we do is the suprarenal part, the suprarenal restraint that is there, which is opened in the last in a regular way of doing deploying EVA device. So in this, what you do is first you slide out the external slider, open up one of the stents, and then take the suprarenal fixator is opened up first. Like the restraint is gradually released over a period of, say, 10 minutes or so, in a gradual fashion, and so that the fabric actually falls back onto the greater curvature side, and there is a sealing zone which is achieved with it. To be more, if I can go back to my slide. I don't think I'll be able to go back to my
And for
slide.
those of you who are interested, there's a very nice paper describing this technique published by the Japanese vascular surgeons.
Yes.
So you could go to that. Any other questions or comments on this?
Would you have done anything differently? It's me from here. Hello. Congratulations. Very nice case. Retrospectively, would you have done anything differently or not? It's just a simple question.
Retrospectively, I should have taken another brachial axis. That could have made my life a little easier. I could have, but my problem was at that time we did consider taking a catheter through the left brachial or the right brachial. But again, we would have to go through the tortuosity of the left iliac to get out the wire and straighten it out even further. That was the plan. That was in our agenda.
Thank you.
Pradeep?
It did work out.
Thanks for the presentation. I just wanted to find out, is this technique now able to be used with other devices apart from the Medtronic device?
I really do not know about that. I'm only, I have done it with Endurant devices. Actually, the other AAAs I did after that, I actually did the reverse slider technique again and again, and I found that I did not have to do a balloon ever for a type 1 embolic, type 1A embolic. It didn't happen. With the reverse slider technique, the apposition was quite perfect. So that became easy.
Have you used this on a number of cases, and how much follow-up do you really have for this type of patient?
In this patient, we did about 1.5 years back. And following that, it has been over a period of last 1.5 years. So if you not really much follow-up, but what the data in 2019 paper that they suggested, it has been quite successful achieving this.
Nice presentation, Pranati. What are the limitations of reverse slider technique? Any limitations you think?
Yes, your device can move a bit, and you cannot really change the position again. You cannot even slide it a bit more once the suprarenal restraint is opened up. So that would be a challenge, which you could have done. You can take a check angiogram and shift your device a bit or readjust the position. That cannot be done with this anymore.
So if you had fallen short, you would have then planned to put a cuff?
You would have to put a cuff and do a chimney to both renal arteries, at least preserve one.
Thank you, Pranati.
Our next presenter is Charing Moraes from São Paulo, Brazil. She's representing ALCVA, and she'll be presenting limb preservation in extreme conditions with upper limb vein graft via lateral access to the peroneal artery.
Hi, good afternoon. Thank you for having me. I have no disclosures for this presentation. So I will be presenting a case of a male patient. He's 60 years old. I'm sure this resembles many cases that you have seen in your practice. He was previously diagnosed with hypertension, diabetes. He's a former smoker. He had previous limb claudication, and he had a rapidly progressive lesion with pain at rest on his left foot. We started to plan a strategy to revascularization of this patient. He had a good femoral pulse and nothing else. He had a previous angio CT that showed patency of the fibular artery. Unfortunately, I do not have the CT to show you, but we will have other examinations here that will show you his anatomical conditions during this presentation. He did not have a great saphenous vein available for this bypass because he had already been submitted to a femoral fibular bypass previously. And this was occluded, and the other limb also had been submitted to a bypass, also occluded. So we had no great saphenous vein in both inferior limbs to use. So this case was performed by my professor, Professor Nelson De Lucia. He's the author of this material. Unfortunately, he's not here to give this presentation. We firmly believe in our practice that autogenous grafts are the great form of revascularization for patients with complex wounds like this and complex anatomy. This picture I took from Dr. Joseph Mill's presentation at the FIT Symposium a few years ago. This is something that Professor De Lucia goes by in his daily practice, and he has passed on to his students as me. We planned for this patient an open surgery strategy. We used upper limb vein grafts, and we did a lateral approach to the fibular artery. This technique has already been published by Professor De Lucia and has been reproduced ever since. These are pictures from the article he published showing the anatomical feasibility of this access, preserving the fibula without bone resection. These are some pictures from the article, and these are pictures from our surgery in this patient. We used a composition of upper limb veins. We performed the lateral approach to the fibular artery, and we used elastic bandages to prevent bleeding in the surgical site. And this is very interesting in this case because it allows the arteries not to be clamped in any moment, which is particularly interesting in this delicate anatomy. Then we performed end-to-side anastomosis in the fibular artery. You can see here no bleeding, no clamping of the artery. It's a very delicate procedure. This is the final angiogram of this patient. You can see that the proximal anastomosis was in the common femoral artery. You can see here some of the anatomical conditions of this patient. He had total occlusion of the superficial femoral artery, popliteal artery, and here the good outflow of the graft to the foot. Now, about the injury, the foot injury. This is the result of the first debridement that we performed. This patient underwent several surgeries. He used negative pressure wound healing technique, several procedures, and this resulted in an adequate wound bed to receive dermal matrix and later total skin graft. This is the wound after all of these procedures. Reminding you of the first image of the foot that we had when he came to our service. Professor De Lucia rehabilitated this patient in his clinic. He was able to continue walking using footwear designed specifically for his situation and for his bandages and healing process. Using this technique, we have in our group treated since 2011 to 2023, 13 patients. Most of them have already previously been treated with different bypasses, so most of them were redo operations, 65% redo operations, and 35% of these patients used upper limb vein grafts as an alternative. We have freedom from amputation close to 70% in this casuistic. Many of these patients have been in the follow-up, considering the primary patency of the graft, being able to heal their wounds before the graft occluded in the follow-up. So in our conclusion, open revascularization remains a gold standard for CLTI, and we have to come up with surgical alternatives to provide it even for most challenging anatomical cases like this one. Thank you.
while people are coming up, do you know how many pieces of vein he used in that procedure?
How many pieces of?
How many pieces of vein?
Yeah, he used a composition from the cephalic and the basilic vein. Only one venous anastomosis. Yes?
Nicola Troisi from Pisa. Just two quick questions. The first one is, why did you choose the peroneal artery as landing zone and not the retromalleolar posterior tibial artery? Because in the last angio, I have seen two wonderful plantar arteries, the medial plantar artery and the lateral plantar artery. And the second question is a technical question. How did you perform the tunnelization of the upper limb veins in an anatomical way or subcutaneous lateral way?
Yes, great question. We didn't choose the posterior tibial artery because of the extension of the graft, because we were already using venous composition of the upper limb, and this would produce a longer graft that we did not have at the occasion. And we used the anatomical position of the graft, not subcutaneous. Usually we do anatomical.
Thank you.
And is it your practice to base your distal bypasses off of a CTA? Because in my experience, I at least where I work, I would never trust a CTA for a tibial anastomosis. I do all my own angiography.
Yes, we did. We did a previous angiography.
Oh.
This was already our planning because this patient already had a femoral fibula bypass previous, so we knew already that that was the only artery that we had because of his previous imaging, but we also did a previous angiogram in this angiography in this procedure before we started the procedure.
Yes, Dr. Faris, probably for this patient who has a shortage of upper limb veins, I may go medially and do a small resection of the fibula to have a shorter bypass rather than going laterally.
Yes, yes. Professor Nelson De Lucia described this technique preserving the bone. He believes that this improves the patient rehabilitation, so we prefer to do it this way, but yes, that would be also an alternative to avoid the vein composition. Yes.
Thank you.
So I might have missed it, so you did not remove a section of the bone?
Without resection of the bone. Bone preservation.
Lateral approach.
Lateral approach, yes.
Moving on from there, how did you cover the foot ulcer?
Oh, yes, the wound, yes.
Yeah.
So we did the debridement of the wound. This patient underwent like 5 or 6 surgeries, and then we used negative pressure healing therapy to provide a feeling of the wound that remained. Then he used, rotated the hallux skin to cover the wound, and then he used dermal matrix and skin graft.
Thank you.
And how long do you offload these patients after these foot salvage surgeries? And how long would you offload this patient?
The follow-up of this patient now is 1 year.
No, the offloading.
I'm sorry.
Offloading. So
oh yes, perfectly.
You operate on
yes.
the patient. How long do you keep them off the foot?
Oh, a long time.
I sell them till healed,
yeah.
however long that takes.
Yeah, this patient, I believe that it took about 60 days with bandages being supervised by Professor De Lucia himself.
Thank you.
Thank you very much.
Thank you.
Now we move on to the next presentation. Aortic coarctation after TEVAR, Manuel Garcia from SVS.
Good afternoon. Thank you, Dr. Shaw and Dr. Gupta and the World Federation. I don't have any disclosures, except that the center where I work at Grady Memorial is the busiest trauma center in the United States. So we get a fair amount of the cases that I'm going to show. But the challenge in this case is not the case itself; it's the post-op that as management, as you'll see. So the case is a 27-year-old male that unfortunately suffered a motor vehicle collision 2 months before his wedding. And so he showed up with a blunt thoracic aortic injury with a grade 3. With a, you can see on the right, the patient had a pseudoaneurysm on the descending aorta, and so no other injuries, so the patient was treated with the TVAR, pretty straightforward. We size all our patients with IVAs despite having a CT scan, because these cases, a lot of times when we do the CT, they're under resuscitated, so in 20% of the cases we change the sizing based on IVAs. And as I said, the case was straightforward. We used a relay pro graft. The patient was enrolled in a clinical trial. It was for the approval of the graft in the US. And it was actually really good result with good apposition of the graft and exclusion of the pseudo. We did, in all of our trauma patients, because of follow-up, we do CTAs early just to make sure everything is fine before discharge, because we don't know if they're going to follow. And this is, you can see on the CT, on the picture on the left, that the flow is pretty good. I mean, there's no stenosis and there's exclusion of the aneurysm. 6 months later, we do a repeat CT. The patient is asymptomatic, and you see now that finding. And we're in the group, we're debating what to do with that, since the patient didn't have anything else. So the question is, do you leave it alone? You start antiplatelet, anticoagulation, or you do any type of intervention? In this case, we decided to do antiplatelet on the patient. And a few months later, so at 1 year, I get a phone call from the patient that he was really unhappy. First, he had systolic blood pressures in the upper extremities of over 200, and he was claudicating. But what he was more unhappy is like he had erectile dysfunction. And so we did arterial non-invasive studies, had an AVIs of 0.7 and systolics on the upper extremities of over 200. So it was basically behaving like a coarctation. And had the finding, so basically more stenosis right distal to the endograft. We're not sure if this was thrombus or it's basically like intimate hyperplasia, right? So what to do now? Now we did elected to treat him. So we took him to the OR, did an IVAS, and I don't know if in the image if it's clear, but you can see this tight stenosis, and it's basically like, you see it like a line. Let me just draw it to you, like right about there. So we put another endograft. Because it was a clinical trial, we used the same endograft, another Relay Pro, 22 by 100. And you can see here that there was a waste after the deployment. So it was not just thrombus or a dissection. It was really tight, like scar tissue there. We had to balloon it, and with good an angiographic result after. At 1 month, we do a repeat CT, and looks great. So we were all doing high fives, but unfortunately, 8 months later, I get a phone call again from him saying that he has erectile dysfunction and he's claudicating. So we do a CT scan, and the same happened. So like that, you can see that image right there. So the question was, now what do we do? So I didn't want to put the same stent graft, so I elected to a different stent graft, different fabric. So I used a Gore graft with PTFE. So treated it, balloon it. Now obviously we're covering more aorta every time we do this, and with a good angiographic result. Had a follow-up CT a couple of months ago, and so far, so good, but I'm just dreading I'm going to get the phone call from the patient that this happened again, and now what we're going to do. So I would love to hear your opinion. My thinking is if this happens again, I'm probably going to need to do an open repair. And that's it. Thank you.
So, Dr. Manuel, what were the findings on IVAS when the patient came first time with the stenosis?
So it was less than like 5 millimeters of a really tight stenosis, and there was a big gradient between the first time when he had the stent graft, or the first
following
stenosis.
The stenosis.
Like on the IVAS, you can see like a really tight stenosis right there, and didn't look like it was thrombus. It looked like basically like intimate hyperplasia.
Okay. Yeah, Pradeep.
Hi, thanks. Pradeep Mistry from South Africa. We do see quite a lot of blunt trauma coming from South Africa, but we are fortunate in our patients very seldom follow up with us unless there's a really big problem. Have you considered using the ZMed stent, which is a nitinol-based covered stent, dedicated stent for coax repairs, higher radial force? That may be the better solution here.
Yes.
If the patient comes back.
Thank you for your question. That's a great point. So I was looking in the literature, and there's only one case reported like this, also in a young patient in the Netherlands, that they use a Palmas stent. So similar to like good radial folds, but a CMED would be good on cover. Maybe that's what I do next time. Hopefully it doesn't happen, but that would be a good option before doing an open repair.
Jason Churn from Melbourne, Australia. Look, I realise we've got the benefit of hindsight here and looking at this case retrospectively, but I would ask you if you would want to go back through your imaging, especially initially, because this looks very much like a distal stent-induced new entry tear that we'd see after deploying a stent graft in a dissection. And I wonder if that's really what's going on, is that you've got essentially either an intramural hematoma that you've missed or a developing dissection. You've now put a stent graft in. There's a little intimal flap that's sitting at the bottom of your stent graft, and despite putting in a second stent graft, you've either caused another one or pushed that new entry tear and intimal flap further down.
And that's a fair point, and I've been thinking about that, but on the original CT, you don't see, on the angio and on the CT at 3 days, you don't see anything. It looks totally clean. Like we've gone back. So I did a CT at 3 days, and it looks totally clean. There's nothing there.
But perhaps your solution ought to be, instead of putting in a high radial force stent, to treat it like a dissection.
Like before, well, I mean, one of what I thought it was probably the cause is like, I mean, I was oversizing this too much. I mean, the aorta was 19 millimeters on IVAS and on CT, and this patient didn't change much, and I used a 22 millimeters, so there was not much oversizing. I didn't balloon, so like, yeah, it could have been a dissection. For me, it looks more like the patient is like getting into my hyperplasia on the distal end, but yeah, it's been challenging. I don't know why this patient keeps doing it.
Any other questions? Well, did this patient have any family history of any aortic aneurysms or any aortopathies, or is it worth getting him genetic tested?
No, nothing. He's a trauma patient. I haven't tested him, but no family history of anything. I mean, pretty healthy before.
Thank you.
Thank you.
Our next presenter is Dr. Tsunushi Kikuchi from Japan, representing the Japanese Society for Vascular Surgery. It's a CLTI case with unsuccessful EVT and declared major amputation for lack of distal targets.
Hello, everyone. I am honored to be here. Let me present this case as a representative of WFVS. My name is Shinsuke Kikuchi. So I have no disclosure. So I need to show the big difference of patient background CLTI patient between Japan and the European countries, USA. In Japan, most of patients have diabetes mellitus, especially half of them have the end-stage renal disease on a regular dialysis. Based on Japanese database of CLTI treatment, although proportion of EVT gradually increased with time, bypass surgery was still important revascularization method for the Japanese CLTI patient. Primary amputation was performed in about 2.0% of patients. I share a case declared a major amputation after unsuccessful EVT. 75 years old male, he had diabetes and ESRD on dialysis. EVT was unsuccessful at the previous hospital due to the loss of run of arteries. His right foot formed a large abscess. Increased white blood cells and high value of CRP were observed. Ejection fraction was low due to the coronary artery disease, and fortunately, his ambulation status was preserved. Limb severity was wound 3, ischemia 2, foot fracture 3, indicating Wi-Fi stage 4. Foot abscess was immediately drained by tissue incision. Cardiologist gave up after POBA to peroneal artery and the PTA due to poor runoff and informed him major amputation. However, he decided limb preservation and came to our department. As you can see, the angiography, although distal runoff was poor, there is a healthy artery in the dorsum. According to Planck concept, patient risk was expected. We usually use a Japanese calculator for COTI patient, showing he was categorized into the standard risk when open bypass was selected, not EVT. Infrapopliteal artery grade was ATA4, peroneal artery 3, PTA 2, respectively. Graft stage was 3 because ATA was selected as target arterial path based on angiography of the previous hospital. Preferred revascularization was open bypass. Preoperative vein mapping showed the GSB availability. He was standard risk, but perioperative cardiac event was concerned. That's why we decided nerve blockade, which is applied without general anesthesia for this bypass surgery to reduce patient stressfulness. Foot infection was well controlled by drainage and antibiotics. X-ray showed no calcification in dorsum. Intraoperative angiography showed a patent lateral tarsal artery, as you can see here. I want to share with the intraoperative findings. As you can see, lateral tarsal artery was easily exposed. This artery was not calcified, appropriated for distal target. Femoral tarsal artery bypass was performed with the in situ manner using ipsilateral great saphenous vein. Completion angiography confirmed no morphological abnormality of vein graft and distal anastomosis. Postoperative CTA demonstrated patency of vein graft after surgery. This graft actually was patent for more than 3 years without any interventions. Wound healing achieved at 3 months after surgery with multiple debridement and skin grafting. His walking ability was also preserved. No recurrence of ulcer was observed for 3 years. This present case was no option? I don't think so. The answer is no. He had a nice distal target for distal bypass surgery. Even if there was no flow on the angiography, DUS is so useful to detect distal target by checking the color Doppler and the compression of the artery. In conclusion, open bypass was durable and the alternative to unsuccessful EVT for COTI. Appropriate revascularization and treatment strategy for COTI could be associated with preservation of functional limb. Thank you for your attention.
Yeah, Jay, go ahead.
Yeah, a very nice presentation. Thank you. You give us a lot of hope. What will be the diameter, target diameter of the artery, lateral plantar artery? Like, will you go at 1 mm vessel or less than that?
Yes. In this case, lateral tarsal artery diameter is around 1 millimeter.
Okay.
Yeah, it's enough for the distal target.
So I go ahead in 1 mm vessels if I listen to a talk and good results?
Yeah.
Thank you.
So were you able to, in this case, you did a diagnostic angiogram with AP lateral foot to delineate the lateral target?
Yes. In our department, we always usually check the angiography by CT and the intraoperative angiography from femoral artery or distal popliteal arteries. So because intraoperative angiography showed more clearly to check the distal target. Yeah.
And then do you correlate that with ultrasound sometimes, preoperatively, your technician?
Yes, before surgery, we always check the patency and the calcification of the distal target by the US, by myself. Yeah.
Yeah.
Hi, again, Rebecca Riachi from Mexico. So I want to ask you, how long does it take to close that injury?
Oh, sorry.
How long does it take to close all the injury in the foot?
As operation?
To heal.
No,
To heal.
when it comes to the ulcer on the foot, how many weeks or months does it take to heal the foot?
Actually, 3 months.
Do you use any negative pressure machine?
Oh, yeah, I did. So this patient treated with the antibiotics and also NPWT technique. So yeah, we continue opening the wound to drainage to control the infections.
Okay.
I think 1 month or 2 months in this case. Then we put the NPWT. Finally, we put the skin grafting, and we got wound healing.
Okay, thank you.
Yeah, Dr. Kikuchi, another question for you. When you perform the angio and you do not see any of these named arteries, if you do not see a graftable artery on angiogram, what would your next step be? Would you explore and check? Or
we talk about completion angiography?
No.
No?
Preoperative angiography.
Preoperative. Could you tell me again?
If you do not see any artery, let's say you do not see the plantar or the tarsal artery.
Sure. We check the ultrasound. Yeah, we check ultrasound. Okay. Yeah. So some patients have severe calcifications. So, and low flow, or that's why we cannot judge the patency of the artery by the conventional angiography. It's difficult to judge.
Coming back to the slide, the first slide you showed, or one of the first slides, comparison with the incidence of diabetes and stage renal disease. What is the reason that the incidence of end-stage renal disease is so high in Japan? Is it salt, or is it? I mean,
it's a national problem. So, actually, so Japanese government insured all the patients with ESRD. That's why so patient can treat with their CKD. So, it's an insurance is very good.
But it doesn't explain why the incidence is much higher in Japan as compared to other countries.
It's Asian countries is similar.
Okay.
Between Japan and Korea and the Chinese, I think it's
But it's less in India, right?
No, India it's very high.
Also?
But in India we do explain with the very high incidence of diabetes.
Okay. Which is not the case.
But what we were discussing earlier may be a very high salt intake in Japan. That is one of the
Yeah, that's probably part of the reason. Thanks.
One more question.
Yeah, hi, Edward Chok, Singapore. So congratulations on a great case. Just a few technical questions. First, the problem we have is usually the veins are not suitable. So can I ask you, what is your minimum diameter before you would consider no longer suitable for a bypass for the vein? And secondly, there's often a size mismatch. Do you do reverse or do you do in situ routinely?
Okay, thank you for the questions. So first question. So in general, 3 meter in diameter is usual for all the world. But in your department, actually, so 2.0 millimeter in preoperative beam mapping is enough for the distal bypass, actually. So, and the second point is size matching for the distal target. So 70% of our bypass grafting is performed in situ because of the beam size to the anastomosis size.
Thank you, Dr. Please join.
Thank you.
The next presenter is Dr. Pekka Aho from Helsinki, representing the European Society for Vascular Surgery. He'll talk to us on T-branch challenging case.
Thank you for the opportunity to give this talk here. I come from Helsinki. I have no disclosures. This is where we started. We put in a standard TVAR T-branch case in a patient, and at this stage we should have noticed something is wrong. And actually we cannulated an accessory renal artery and put in the bridging stent, and of course it's exploded because it's far too small, and the patient lost blood pressure, so we had to coil the stent, occlude it to save the life of the patient. So now we have no access to the right renal artery, and this is the CT image I checked afterwards, which was done before the procedure, and we should have noticed that there's the normal renal artery and the accessory renal artery, which we forgot. So what to do? We didn't put the left iliac limb on purpose on place because we wanted to do this stage to preserve, not to have spinal cord ischemia. That's our routine. And we did a CT, we saw that the right kidney is still functioning, and it has perfusion from the aneurysm sac because the left iliac limb is not yet there. We wanted to preserve the kidney, so what to do? This is an angio from the aneurysm sac, and you can see that the kidney is perfusing there. The iliac limb in this Cook device is 11 millimeter, the stump, and the common iliac artery was 18 millimeters. So we needed something in between here which would have a side branch which we could connect to the renal artery. Something like this, and connect it there. This would be ideal. But unfortunately, such grafts don't exist commercially. I actually asked the company, and they said, oh yeah, we can possibly make it, but it would take months to develop, and they had never done that. But fortunately, there is a graft for that, and it's C-excluder main body, but it has to be reversed. Can that be done? No one knew. So we tried it on the table. We cut off the lines and removed the deployment knob and the safety handle, cut up the top of olive and detached the graft. Then reversed it there and pushed it in the introducer sheet, made a pusher from the dilator, and then removed the lines in correct order. So we deployed it in the introducer sheet and deployed it like a pullback method. So now we knew that it's possible. Nice. So we put it in the patient and deployed it, and it was a perfect match, perfect length, perfect match for the iliac limb, the short limb in the core graft, and also in the common iliac limb. There you can see that it's popping up the limb, and there's an image also where you can see that there's the short limb of the reversed gore graft. And then it was through that graft, through that limb, it was very easy to cannulate the renal artery and put in there a covered stent and continued downwards with a little bigger one, and then inside that we put a IBE iliac limb graft. So we had a perfect match graft and a good perfusion to the renal artery. And later on we did CT with 3D reconstruction, looks quite nice, and also the CT image shows here some type 2 endoleak actually, and also that the limb is coming nicely down to the iliac bifurcation, and there's just enough space so that all three limbs sit nicely together and stay patent. And this was done 2 years ago, and it's still patent and normal renal function, and the patient is doing fine. We published, of course, the technique. Thank you.
It's a really outstanding case. I just actually learned to do that a couple weeks ago for a patient. The rep taught me how to do it, and it worked. And can you explain the extension of the limb into the renal artery? Which device did you use? The VBX or Vibon or?
Yeah, we had VBX, 6 millimeter VBX to the renal artery, then followed by 8 millimeter VBX, and then the IBE internal component, which is 16 millimeter, and then goes to 10 millimeters.
Okay.
So it's 16, 10, 8, and 6. Yeah.
Wonderful.
It's a lot of hardware in one patient, yeah. But definitely extremely well managed to, come out of a difficult situation and salvage the kidney and the patient really good.
Lucas Freire from Campinas. Congratulations for the solution. Did you consider laser-assisted in situ fenestration for a solution?
That would, yeah, we did, but we don't have that laser machine yet. We tried to get it for 2 years, but the company doesn't sell it to us for some reason. I don't know why. But that's a good solution also that we considered. And we also considered a reversed chimney to the common iliac, but the common iliac was 18 millimeter, and I believe that there would be an occlusion in either the common iliac or the graft some later on, and maybe endoleak, I don't know.
Has anybody else in the audience used a similar technique of reversing either a gore limb or gore main body?
Yeah, I'm Dr. Meda from India. We do reverse the limbs, aortic limbs. Sometimes we got a mismatch of, we need to reverse the aortic limbs, but not the gore graft like the main body, which we do. Yes, in this case. But we do reverse the limbs. Sometimes the distal part is aneurysmal, the proximal is normal. In those conditions, we need to take out the stent graft and resheath it, and we put the limbs reverse. This is the first time. Yeah, okay then, yeah.
Yes, we do that also. We've done several cases like that. That's how we kind of thought that it might be possible to do that same thing with the main body also.
Yeah, sometimes we need to come from the axillary artery where we need to reverse the graft and deploy, where you want a precise placement of the stent graft. Distally, we do reverse the main bodies.
Yeah.
Aortic. Okay then, thank you.
Thank you. So was there someone who done this also? With the main body?
I did it for a limb. I did a limb.
A limb, okay. Main body. Anybody?
There was one person that raised their hand in the audience.
That was a limb you used? Okay, so just because I don't know, no one told that I've done this before, but I don't know.
Well, I think you taught a lot of people a nice trick today. They're all going to want to go home and try it. Thank you. We're good. Thank you very much.
Thank you.
Thank you. Okay. Our next presenter is Dr. Vasuvadan from New Zealand, who's representing the Australia-New Zealand Society for Vascular Surgery, presenting pseudoaneurysm from right coronary button with previous ascending stent graft.
Thank you very much, Paula, and to the organizing committee for the opportunity. I'm just going to present a fairly complex case of a patient who was sent to us. These are my disclosures. It was a 70-year-old man who came from another institution to us with a pseudoaneurysm around his ascending aorta, which was not quite clear at that point of time. He had a pretty complex past history, starting with a mitral valve replacement in '99 and a type A dissection for which he had a repair, which included an ascending arch, a hemiarch, a bioprosthetic valve, and a coronary artery bypass graft as well. He also then underwent a descending aortic TIVA for a residual dissection, and in 2019 he had a redo ascending and arch replacement and a reimplantation of his right coronary artery button at that time. At this time, he also had a carotid subclavian bypass, so basically his cerebral circulation was running via his left subclavian artery. And he also had a permanent pacemaker. He had obstructive sleep apnea, and he had quite significant heart failure and a right heart enlargement at that point. and also had atrial fibrillation amongst his comorbidities. So this is his CT scan when he presented to us. And you can see that there's a whole heap of metalware, and you can see where the pseudoaneurysm is coming just proximal to where the stent graft lands. And you can see that on the recon as well. It was quite a large pseudoaneurysm, which was occupying a lot of area in his mediastinum. So there was a lot of discussion initially as to how we should treat this particular patient, since he was quite unfit at that stage, and straight away got a no from the cardiac surgeons. And the cardiologist had a good look at it and said it's not really ideal for an ASD or a VSD closure device, and therefore we were left with very little option but to look at some sort of a TIVA device with a very tiny little space that we had to fit that into. And the only advantage to this was that his right coronary artery was actually occluded, which is probably why it formed the big pseudoaneurysm. So the challenges obviously were that we had to land very close to the coronaries, and his left being the only one which was open, which also had quite a critical distance. And also had to account for where the left subclavian was coming off more distally. And if you look at some of the air devices that Cook does, they have a fixed length, and that was going to be a problem with this particular patient. And also the fact that we had to preserve that single vessel that was supplying his head and neck. And because there was a whole heap of metal, we were not very keen on using some form of a branch device that could be used for the left subclavian. We had to obviously land in zone 0, and it's not something that's alien to us, as we do a lot of arch endovascular devices. The optimal length of the stent graft was going to be an issue, so and it also had the nose contour traverse through the aortic valve. So it had to be a custom graft design, and there was some significant discussions with Cook at that stage, who came up with this particular graft design. A slightly modified A graft with an uncovered stent right at the front of it. And this was the way that we did the deployment, through a femoral approach, had the graft go up, had a wire through the aortic valve, had a catheter through the left subclavian artery to know exactly where it was, and had, normally what we would do is to use IVC occlusion, but on this occasion he had such a large hepatic vein that we couldn't occlude the IVC, so he had overdrive pacing for this. And we managed to deploy that quite successfully, and there you can see the completion angiogram. Luckily, we completely occluded the orifice of the false aneurysm. His postoperative course from then on was quite uneventful, and he was discharged on day 3. The one good thing about this was that his breathlessness and his heart failure status started to improve, and it became obvious to us that the big collection in his mediastinum was probably responsible for a lot of his dyspneic symptoms and the symptoms of heart failure. He had a follow-up CT, and that was what the follow-up was, with no filling and some shrinkage of the sac itself. So in conclusion, it was a pretty hairy zone 0 TIVA with preservation of a single arch vessel, which had no other open surgical solution, so it had to be a custom-made design. And it was obviously after a lot of MDT discussions, including with the Cook planners, that we were able to successfully execute the plan. Thank you very much.
While people are coming up, Vasu, how long did it take to get that custom-made piece of graft?
In our part of the world, we are actually quite fortunate with custom-making grafts. So once we got the design all sorted, it only took 2 weeks for us to get the graft.
I think it would take 6 weeks in the US, or something like that.
Which is very fortunate, because of my work with a lot of the arch grafts, I have a direct line with the planners. So, it helps.
Yeah, excellent.
Nicely done, Vasu. One question, how long was the bare stent and how close to the aortic valve did you go?
So the bare stent was still about nearly a centimeter from where the valve junction, where the infundibulum was, and it was probably covering the origin of the left coronary. It was obviously going to straddle the left coronary, but there was good flow as you saw in the final angiogram.
And did you have any barbs on that to fix it? Or?
No. It doesn't have any barbs.
Did you do any genetic testing? This patient has connective tissue disorder, looking at back 25 years ago with mitral valve surgery and so forth. Do you know?
He did have genetic testing. There was nothing that was identified. As he'd been through several institutions and finally came to us. So he was pretty well tested by the time he came to us.
May I ask you one question, sir? How do you preserve or how do you ensure during this operation that you have preserved the left coronaries? Did you cannulate the left coronary, put a wire there?
We actually thought about it and discussed it. Because it was at a funny angle where the left coronary orifice was coming out and it was a re-implanted coronary artery, the advice was to make sure that we mapped it on the angio or not actually cannulate it. We did ask the cardiologist about whether it would be a good idea to cannulate the artery ahead, and they probably were not very keen on cannulating it and wanted to rely on quite accurate deployment of the device itself. And there was almost 3 to 4 millimeter gap between
the two,
where we landed and where the left coronary was.
Okay, thank you, sir.
And what was the length that you needed to cover?
We needed to cover, so that's where the catch was, because I think the air graft was about nearly 10 to 12 millimeters longer than what we needed.
Yeah.
So they had to kind of custom make. And I don't know if you know about the Cook air grafts, because they didn't have a very good track record. So they're very reticent on first giving the air graft and number 2, modifying it. So it took a while and a lot of discussion before they parted with it.
And the case that I got involved was a pseudos after cannulation, and same thing, cardiac surgery, they don't want to do it because they do a sternotomy and the patient bleeds, right? So unfortunately in the US we don't have options like that. So I've used aortic cuffs and coming from the carotid to...
Correct, yeah. And that would have been a pretty valid option, except that we just couldn't get a cuff that was going to fit into that part of it. And we also looked at, so we've had another coronary button which was quite smaller, that we use a ASD closure device, and it worked quite successfully. But in this case, it was actually quite a large aneurysm, and we were worried that it might just get pushed into the sac.
Thank you very much. It was excellent. There was a question left over that we missed regarding the discussion for Dr. Aho. It was a virtual question. Why not use cautery for direct fenestration with the Benson wire, as you only needed to open it about 5 millimeters? Because instead of having a laser, they're proposing using a cautery on a Benson wire to perforate the graft to open the. This is for Dr. Aho.
No, sorry, I couldn't get the question really.
Sorry. This was a leftover one that we missed. It's on the virtual. I just thought we'd pose it. The question was, for your case, to reopen that area to get into the renal, why not use cautery onto the graft that you placed for direct fenestration with the Benson wire to burr a hole into the graft?
Oh, you mean to do a hole in the graft?
Fenestrate the graft.
Yeah, that was previously asked also, that why don't we use laser to do that, and we don't have the laser machine. But it can be done also with cautery, yes, I know. But I thought that should only be done actually according to ESVS guidelines. That should be only do in emergency cases. And this was not an emergent case. We did that a month later. Okay. And I believe that this is much more durable and like we can trust on the graft.
Okay. Yeah, thank you very much. So we have another 3 speakers, and we won't have enough room on the stage, so the organizer suggested that the faculty go back to their seats, and then we'll bring up the next 3 speakers.
Thank you.
Sorry, thank you very much. Okay. So our next, go ahead.
Yeah. So the next speaker is Dr. Narendranath Mehta, representing the Vascular Society of India. He will speak to us on physician-modified stent graft for ruptured suprarenal aortic aneurysm in a patient who was retrovirus positive.
Good afternoon, all. India is being a developed country. We don't get a customized branch of fenestrated grafts, even though if you order, it will take 3 months to get it. But conditions like where we need to deal the patient on table, example, there's a ruptured aneurysm. This is the case we're going to discuss now, and there's nothing to disclose. Here is the case of 53-year-old male with a sudden onset of abdominal pain 6 days, and no prior episodes in the past, no history of fever, GA bleeds, cough, and dyspnea, and recently diagnosed with hypertension. And his blood investigations are normal, except that he has got a retroviral HIV positive and HBsAg positive with the CD4 count 480 cubic per millimeters. And this is the CT scan showing a suprarenal aortic pseudoaneurysm with impending rupture involving at the visceral area, mainly involving at the SMA and the celiac, just above the renals. And you can see the hematoma anteriorly to the aneurysm. And the options of the treatment is, one is open surgical repair, and the second is hybrid repair by bypassing visual debranching, followed by stent graft, and the other is fenestrated EVAR. And being a positive case like viral infection, HIV, and HBsAg positive, we don't want to go with the open surgery, then we plan for a fenestrated EVAR, physician-modified customized stent graft. And these are the measurements. And supra-aortic aneurysm, the aorta is ectatic. The total area needs to be covered is more than 25 centimeters to 50 mm. And we don't have any stent graft available to have a single stent to make a physician-modified stent graft. That's why we decided to go ahead with the 150 distal and 150 proximal stent graft, where you have overlapping of 5 centimeters. These are the diameters of proximal normal stent, aortic diameter 26 mm. This is how you can see. These are the diameters where the normal aorta of descending thoracic aorta to be an average 26 mm. And the ectasia above the aneurysm is 34 mm, and the normal area intrarenal aorta is 19 mm. This is how we need to match. We need to get around 25 centimeters of coverage, where we decided to have with the 2 stent grafts, distally with the fenestrated stent graft and proximally with the normal stent graft. And these are the clock positions of the SMA, and we decided to coil embolize the celiac. We need to revascularize the SMA and bilateral renal arteries. And these are the SMA clock position, is the 12 o'clock position. And if you see, the left renal is around 3 o'clock position, and the right renal is around 10 o'clock position, 9 point. And this is how we decided to do fenestrations. Depending on the CT scan, or the clock positions have been already mentioned, and the diameters of the vessel SMA is 8 mm, and we tend to do 1 mm lesser the diameter of the reason is we don't want to get any type 3C leak. That's the reason we do fenestrations of 1 mm less than the original diameter of the ostium. And this is how before resheathing, we always fix the nose cone so that we don't want the barbs or stent to open up during our sheathing or resheathing device. And we open up the stent, and as per the measurements previously I told, from the proximal to distal, as per the CT scan, we made a fenestrations for SMA and bilateral renal arteries. And we use a ophthalmic cautery for the fenestrations, and we use isoprolene to reinforce, and we use a Fielder XT wire. I don't know if you know aware of the Fielder XT wire, which is a very radio opaque wire, which will help us to reinforce the fenestration, because we don't want any fenestration after stenting to have a leak. That's the reason we reinforce with the Fielder XT, the proximal part of the wire, which is very radio opaque. This is how we do fenestrations with the 6-O-proline. Here we're doing with the SMA fenestration. And one more thing is, we'll take a 12 o'clock position as per the 8 markings. We have 8 markings on the stent graft. We take it that 8 markings as a 12 o'clock position. That's how we do 3 o'clock and 9 o'clock position markings for the renals. and we resheath the stent graft either different ways of. One, we regularly follow, say, umbilical tape technique, where we'll constrain the stent graft before resheathing, or else sometimes we do a silk, or sometimes we use a resheathing devices for the TAVI and all. We can use it here for resheathing the stent graft. And this is how the fenestrations looks like at 12 o'clock, 3 o'clock, and 10 o'clock for the SMA and bilateral renals. And you can see the distal angiogram showing a suprarenal pseudoaneurysm with impending rupture, and we coil the celiac, which you can see the coiling of the celiac artery. And before, we always pre-cannulate at least one of the renal and one of the visceral vessels, because we don't want to miss. If something happens during the procedure, at least we can do a chimney, or we can bail out the procedure. That's the reason we always pre-cannulate one of the renal arteries, one of the visceral vessels. That's what you have seen. The pre-cannulation is done for the right renal artery and the SMA. And this is the deployment of the distal stent graft. Once you deploy it, once you see the SMA fenestration, then we'll cannulate from above for the SMA. And after that, we try to cannulate the left renal and the right renal after deploying the stent graft. And after deploying the distal stent graft, we cover the proximal stent, which the completion angiograms. This is a deployment of the proximal stent graft to cover the proximal area ectatic. And this is how it looks, the final completion angiogram, where we can see complete exclusion of the aneurysm, pseudoaneurysm, which has been. And this is a 3 months follow-up CT scan, which you can see there is no endoleak. The aneurysm is totally excluded, and we got a very good result. And creating a physician-modified stent graft is an effective technique that is useful when validated treatments are not available. However, it is not standardized technique, and the long-term consequences of modifications remain unknown. Thank you.
Thank you. So we have about 3 minutes for questions, as he ran over. Anyone from the audience? So he had a retroviral. How active was the retroviral infection? Was he well controlled on meds?
Yeah, it's well controlled before the procedure. It's like 480 CD4 count, well controlled. Thinking that it's a mycotic aneurysm secondary to retroviral infection, patient is on long-term antibiotics, which we gave. It's been done almost 1 year back, this case, and is still on antibiotic. But we don't know the proper protocol. We are covering gram-positive and gram-negative coverage, cephalosporin 3rd generation with vancomycin initially. That's what the patient is doing good since 1 year. The patient.
So what's the long-term antibiotic that the patient is on?
He's already been on since initially we put him on vancomycin and 3rd generation cephalosporins to cover whole of gram-negative and gram-positive coverage. But now he is on cephalosporin since 1 year. So we would like to stop it after seeing his CD4 count and rest of the things. And we would like to take one more CT scan, follow-up CT scan after 1 year.
Any questions from the audience? How long did it take you to make that device? How long did the case take?
We always do on table. If someone is preparing for the puncture sites and all, I would like to do the stent graft sheathing or resheathing. It hardly takes 45 minutes to 1 hour. Because this is, I think it's almost like 10 cases we have done from last 5 to 6 years. Okay. Physician modified stent grafts. Okay. But this is the 3-vessel fenestration which we did it. Yeah. 2 cases of 3-vessel fenestration, rest of the cases are 2 or single-vessel fenestrations. We usually do 1 or 2. Okay. But this is the case where we can't do open surgery, patient is on retroviral infection. That's the reason we took a decision to take a fenestration. Yeah.
Yeah, Pradeep.
Enjoyed the presentation. Our experience with HIV aneurysms has shown that in the heart, naive patient, yes, you do get opportunistic infections and find that the aneurysms can be mycotic. But now with patients on adequate ARVs, we're finding that these aneurysms are not mycotic at all and must be managed like any other degenerative type aneurysm. So we are not covering our patients with long-term antibiotics or
No, that's the reason initially we started with the dual antibiotics. We stopped it after 3 months, confirming with our physician. And now patient is on cephalosporin, 3rd generation. Now even we had to decide to stop even that antibiotic course after getting the CT angiogram. Because it's been a 1 hour follow-up. We want to get the CT iotogram to look for anything, any infection, active infections.
Thank you. Anything else? No.
Yeah.
Thank you very much.
Thank you, Narendra.
Our next presenter is Dr. Edward Chok from Singapore, who's representing the Asian Society for Vascular Surgery and will present a challenging peripheral arterial disease case.
Thank you very much, Palma. My name is Edward Chok, so I'm a vascular surgeon from Sengkang General Hospital, Singapore. Thank you to the World Federation of Societies for the opportunity. My case is a 67-year-old male with diabetes, hypertension, hyperlipidemia, presented to me with 2 months non-healing web space ulcer, previous 2 failed attempts at angioplasties. And this was his duplex scans, which we do routinely before our angioplasties. So above the knee, fem-pop, nothing too difficult, but below the knee, both of the tibial arteries have got long CTOs, primarily. The problem here with the posterior tibial artery is that there is no stump, so antegrade is anticipated to be quite difficult. Previously angioplasty ATA, early recurrence of ATA with CTO. So this is the this is diagnostic angiograms showing at the top above the knee, not too difficult, but below the knee, that's where the difficulty lies. The dominant artery is the peroneal artery, giving rise to a posterior branch to the posterior tibial artery with a reasonable lateral plantar artery. And so the decision was to try and get inline flow through the posterior tibial artery into the lateral plantar artery. At the top, at the popliteal artery, there was no proximal PTA stump for any antegrade crossing, so the threshold for us to go retrograde is actually quite low. So in this case, I use a fluoroscopic method with a calcification to do a retrograde puncture of the LP of the posterior tibial artery. By this stage, I still didn't know, but I'd caused a dissection at the retrograde puncture. The clues for these should have been apparent when I try and snare the wire at the popliteal artery. I had difficult entry into the TP trunk, and I was unable to break into the TPT lumen. And this is what I get, quite a dirty looking angiogram picture, and it was difficult to pass the wire up. And I should have stopped at this stage, but I persisted, and what I did was to use a 4 millimeter balloon to crack the lumen from the top, and after cracking it from the top, then I was able then to advance my wire from the bottom, and I was then able to, in inverted commas, successfully snare the retrograde wire from the bottom. So after this, I did a balloon angioplasty of the entire posterior tibial artery. By this stage, little did I know that I was angioplasting a blind ending into a blind ending vessel because of all the dissection. And so this was it when I tried to pass the wire into the lateral plantar artery, caused a perforation, and I was unable to cross back into the retrograde puncture site and get into the lateral plantar artery. So this was the baseline angiogram, and now I've got a problem here in that you see okay, let's have a look, see if I can. Okay, anyway, now I've got a problem now that I've completely destroyed the lateral plantar artery, and the patient's now got acute ischemia. So the bailout was to try and then cross via the occluded ATA into the dorsalis pedis, into the lateral plantar artery, and finally into the posterior tibial artery. And so initially crossing the anterior tibial artery wasn't technically too difficult. And this is the angiogram. And then I thought I would be able to get from there through the pedal plantar loop approach into the posterior tibial artery. However, at this stage, the wire kept going into an alternative vessel, and I was unable to just get the wire to go around the pedal plantar loop. So now I've got a problem in that I'm unable to cross the LPA from the antegrade position. I'm also unable to do the pedal plantar loop approach from the dorsalis pedis. The patient has now got a wide cold foot. So the patient is now looking at a below knee amputation. But you can see that the wire going into this artery, this is the medial plantar artery. So I attempted to do a pedal plantar loop approach from the medial plantar artery using an 014 command ES wire from Abbott. And I was able to successfully cross the medial plantar artery into the posterior tibial artery, and I was able to crack open the dissection at the retrograde puncture site. And so from there, once I'm able to crack open the distal puncture site where I'd already dissected, I was then able to perform a pedal plantar loop approach from the antegrade position into the LPA, and this was finally successful. And so I was then able to complete the procedure, and I was able to angioplasty the entire pedal arch. This was done on the 14th of February, and at this stage I was feeling a lot better about myself, and I thought the shape of the wires looked like an inverted heart shape, which is very typical for if you've got all your wires around the LPA and the MPA. And this was the final angiogram results with a nice reconstruction of all the anterior tibial artery, posterior tibial artery, with a reconstruction of the plantar arch. So I went on to do amputations of the 2 toes. This was at 2 weeks. At 4 weeks, there was nice granulation tissue. So for me, learning points from this case was that during any retrograde puncture, beware of causing dissection at the puncture site. This will result in inability to cross the puncture site from the antegrade fascion and will result in a blind ending vessel, results in an acute limb ischemia. The medial plantar artery can be accessed retrogradely from the dorsalis pedis and can be used as a source to crack the PTA entry into the LPA. Thank you very much.
I think a very well salvaged situation. So when you puncture the plantar arteries, the medial or the lateral, do you do it under ultrasound guidance or fluoroscopy?
It depends. If there is, for me, posterior tibial artery, there's a very calcified artery. For me, it's simpler to do it under fluoroscopy. Yeah. But if it's not calcified, then ultrasound guided.
I see.
And you said this patient did not have vein?
No, not suitable for a bypass.
Okay. Was the procedure being done under, let's say, local anesthesia or under some block? Because when the patient had acute ischemia, did the patient bother you?
Because our CLTI cases are usually complex, about 40% of them will require some form of retrograde puncture. So our cases are mostly done under general anesthesia.
I see.
And that allows us for, when we puncture the foot arteries, then it just makes the procedure a lot simpler.
Okay.
Yeah, thank you for the presentation. Probably in patients with a single vessel runoff, when we have a reasonable plantar artery, I think as vascular surgeons, probably even if he has no saphenous vein, we can get some upper limb veins and do a bypass from the beginning rather than trying this, because I noticed that he has ulcer in between the first and second, and then he lost his 2 toes. Probably if you do a bypass from the beginning, you can save both toes.
Point taken. 90% of our procedures are still normally done under with endovascular first approach. 10% will be bypass surgery, and to be honest, our practice for open bypass surgery is reserved for those who have failed endovascular therapy. This patient, although he's only 67 years old, has multiple comorbidities, including he was just recovering from a recent stroke as well. And so for us, we have also done harvested arms from both arms and use a composite bypass to do a long distal bypass. But that, for us, is reserved for 10% of cases. Yeah.
Thank you.
Yeah, please.
Yeah. So thank you for the great EVT technique. So my name is Shinsuke Kikuchi from Japan. So 2 questions. First is that how long did it take this procedure? Second is that what the indication of the bypass convert during the EVT procedure?
Okay,
yeah,
first question, this case took about 4 hours.
4 hours.
Yeah, on average, our complex CLTI cases take about 3 to 4 hours, straightforward cases, because we try and reconstruct all of the tibial arteries. What was the second question? I missed.
It's about the indication with bypass convert during the unsuccessful EVT.
Indications.
Yeah, indication. During EVT?
So failed EVT is an indication. Secondly, we need to obviously have a reasonable bypass target. And thirdly, our threshold for getting a suitable vein is 2.5 millimeters, and the patient has to be fit for it. Yeah. And also in answer to the question from an earlier gentleman, I think for us, we see the advantages of doing EVT first as a first-line strategy because, like in that case, I would be able to reconstruct both the anterior tibial artery and the posterior tibial artery. Whereas if I did a bypass, I'm only going to get blood into the lateral plantar artery.
Thank you.
How frequently you do a retrograde approach for the tibial disease?
30 to 40% of the time. And that's why we generally perform
How much 30 to 40%?
for our patient. 30 to 40%. Yeah. But our threshold for going retrograde is low. We will try maybe 3-5 minutes antegrade, and if we don't succeed, we will go retrograde.
Yeah. Even we do that. It's always good for the patient. You can finish the procedure fast. Initially, you may feel the threshold is very high for doing retrograde. It needs a lot of hardware, like the extra sheet, extra whites and all. But you get a good results if you do retrograde. Even our threshold is very low to do the cases nowadays. We improved a lot, yeah.
I just wanted to ask about radiation protection. Retrograde approach is not so friendly. Do you have any extra precautions?
Well, that's a good consideration. The short answer to that is there is no good solution. There's a lot of radiation, especially since you're now closer to the C-arm. It's not feasible to use lead gloves. With the retrograde puncture, you do require as much feedback, tactile feedback as possible.
Thank you, Dr. Chok. Please join us here.
Great case.
The final talk in this session will be by Dr. Pradeep Mistry, representing VASA, supravalvular aortic stenosis in a child.
Good afternoon, Prem. Thanks, Palma, for organizing this session. So I'm based in South Africa, and my core work 99% of the time is to treat ex-smokers in the adult population. But at our unit, we have quite a large referring center for pediatric cardiology. And from time to time, we get invited to the MDT meetings. We generally find that we arrive there with some trepidation because there's always one or two surprises that they will play to show us. So this case is about a 7-year-old child. Just some background on the pathology, which I think is a challenging one, with supravalvular aortic stenosis, which is a problem of the intima and media, where there is a lack of elastin, resulting in hourglass type of fibrotic strictures, a lot like coax, but this presents in the arch, ascending aorta, descending aorta, truncal branches, as well as coronary arteries and peripheral pulmonary arteries. So patients can present at different stages, and they can be syndromic or non-syndromic. The syndromic complex has a neurobehavioral and craniofacial changes and metabolic abnormalities, known as Williams syndrome. The non-syndromic versions are autosomal dominant and have discrete hourglass or diffuse symptoms, can present with hypertension, congestive cardiac failure, myocardial infarction, and early death. Now, the case we present was published, or at least the early experience of this case, a 7-year-old boy, which they presented to us on this day, with numerous surgical procedures. So this is just a timeline in terms of what this child presented with, and I'd highlight to you at the age of 6 or 7 months, this child had these arch-like stenosis and underwent open surgery for a pericardial patch, bovine patch of the ascending arch. as well as the descending aorta. Subsequently, had 2 episodes where these peripheral pulmonary stenosis were attended to with balloon angioplasty, the second of which was at 17 months, where the patient had pulmonary hemorrhage from this area and required necessary surgery to correct this. Furthermore, at the age of 7, or at the age of 3, subsequently had these arch narrowings worsening. At the age of 7, was presented to the MDT for surgery and turned down for new repeat surgery, and hence we were asked to get involved. So this is the picture we were faced with, and I'll bring your attention to this point there, showing the arch stenosis, which is very fibrotic. You see a very or pre-occluded occlusive stenosis of the left subclavian, as well as the left carotid. Now the challenge here would be, from a hybrid type approach, is if we were to place a stent into this arch or proximal descending aorta, we would be covering this truncal vessels, and also having the issue of proper deployment, perfect positioning, risk of rupture, and tearing the situation. So the plan we went with was an extra anatomical bypass. So right carotid to left carotid bypass, and then a left carotid to subclavian bypass using inverse monitoring and ligation of the left common carotid and left subclavian. And then to place a covered stent. Now we knew that placing a covered stent through this area was going to provide some challenge because of the diameter challenges, as well as the issue with regards to proper deployment with balloon-mounted stents. So we placed first a nitinol Viabahn, called Viabahn stent, 11 millimeters in diameter, 10 centimeters long, to be able to give us a scaffolding to provide us the option to then place a stent within this balloon-mounted ZMed stent to overdilate at high pressure using a high-pressure balloon to decrease that risk of rupture in that area. So this is our initial follow-up image. The patient had a successful procedure. I'm showing you these images from behind so we can adequately see the bypasses as well as the stent in position. And at 2 months, the patient was now normal tensive, free of claudication. Antihypertensives were stopped. At 1 year, similar in terms of follow-up, living a good life. This is a 1-year CT follow-up, and as you can predict, based on the pathology we're dealing with, the brachiocephalic is now significantly narrowed, and the bypasses remain patent. And in the right picture, you could see the stent in stent remaining patent. And now we were faced with a new challenge. So here we considered placing a stent within this brachiocephalic system, also using a covered ZMed stent. Here we placed a through-and-through wire from the right arm with long sheets in order to be able to precisely place the stent in the area, and that was our final outcome with a 12 millimeter ZMed stent. Now these ZMed stents can be dilated in future as the child grows, but obviously this is a challenging pathology, and at some stage open surgery will be required. We don't really know how long this, what's the life expectancy of this child long term, but currently with 3-year follow-up from the index procedure, child seems to be doing well and remains asymptomatic from a lymph flow and from a renal perspective. So what this case highlights is that the pathology at hand here is somewhat different to what we usually work with. I think the peripheral pulmonary stenosis is probably going to be what results in the patient's long-term prognosis, as we don't have answers to how to manage that just yet. Patch aortoplasty is the open procedure, which is the gold standard. Hybrid surgery can be considered in these patients, and we show a good patency at 2-year follow-up. Now, there are some series with regards to open surgery, which is also fraught with high rates of restenosis and reoperation. There are endovascular procedures that have been performed for these stenoses and have been managed relatively well in the short term. So in conclusion, adult endovascular interventionists should be aware of this pathology. Endovascular strategies in children need to be modified and may be better suited in high-risk situation. The stent-in, stent-inlay procedure using dedicated stents for coax should be considered when needed. Proper planning and anticipation of how these stenosis behave should be considered. Extra anatomical bypasses may facilitate stent placement, and lifelong monitoring is mandatory to be able to assess outcomes and manage patients appropriately. Thank you for the opportunity, and please come to South Africa, visit us in Cape Town.
We just have about a minute for any questions.
Okay, can I ask a question about the sizing for a 7-year-old? So what size stents stents you use for the aorta, and what are the considerations for the subsequent growth?
Yeah, I think one of our biggest challenges here was the sizing. So we used initially a nitinol 11 millimeter stent, and the inlay stent within that, which is the high pressure stent, can be taken up to 16 millimeters, but we only took it up to around 11 millimeters with the initial procedure. So the understanding is that if it's a coax stent, you could go and tear that nitinol stent from within with the covered ZMED stent for the future. And similar thought process was taken into account for the ZMED stent in the brachiocephalic trunk. One would assume at some point, if this child reaches maturation or adult age, will require some sort of a total arch replacement.
Congratulations, a great result. For the carotid, what conduit do you use?
Excuse me?
The carotid bypass.
So we used a 6 millimeter PTFE conduit.
Okay.
Because
that might be an issue later on, but I mean, 6 millimeters should be okay, right?
So again, we thought of that slightly oversized, but given the pathology, we also showed that there are some anastomotic stenosis already developing, especially on the subclavian on the left side.
Thank you very much. We'll be concluding this portion of the program. Thank you so much.